Hello again, this is Professor McGinley, and this is part 2 of preterm labor. Therapeutic management of preterm labor is aimed at maintaining the pregnancy as long as possible, even if the membranes are ruptured. Remember, every day in utero is valuable to the developing fetus, unless the fetal heart pattern tells us otherwise. If the mother is toxic from infection, then we will deliver the fetus to preserve her life as well as that of her baby. So the obstetrician has to weigh the benefits of continuing the pregnancy with the risks to the mother and the baby when developing the therapeutic plan. Research has identified 3 factors that are associated with an increased risk of preterm birth, no matter what we do. Cervical length less than 2.5 centimeters, a positive fetal fibronectin test, and a history of preterm birth previously increases the risk of delivering this pregnancy. In addition, if we find that the cervix is dilated 3 or more centimeters, it is less likely to benefit from any type of tocolytic therapy that we implement. We still try to stop the labor long enough to administer 2 doses of betamethasone. That gives us 2 extra days for that baby to be in utero. The OB may opt to administer IV antibiotics for chorioamnionitis. Ampicillin or Zithromax are typical drugs of choice. This patient has a high likelihood of delivering due to the adverse effects of infection on the mother and the fetus. If there are no signs of chorioamnionitis or fetal distress, we can delay the delivery as long as possible. Bear in mind, if the pregnancy continues with ruptured membranes, the risk of developing infection persists. In addition, there is a risk of developing oligohydramnios, which is too little amniotic fluid. If you look at the ultrasound in this picture, there is only 1.8 centimeters of fluid in the pocket that is at the end of the arrow. The normal low AFI is 5 centimeters. If you look up at the top left graph, you can see what the volume should be based on gestational age. And what we really want and are aiming for is that any given pregnancy is going to follow the blue line, which is the mean AFI, amniotic fluid index. We monitor the fetus continuously because too little fluid can cause umbilical cord compression. In addition, we maintain bed rest and do biophysical profiles daily in the hopes that amniotic fluid volume will increase and to assure ourselves that this baby is doing okay in utero. If the patient has contractions and the cervix has changed, which is what true labor is, change of the cervix in dilation or thinning, we have several options for stopping them. We begin with hydration with IV fluids. A dehydrated patient causes uterine irritability, and that causes it to contract. A less commonly used drug for preterm labor is a beta-adrenergic agent called terbutaline. We give 0.25 milligrams sub-Q every 4 hours. We rarely use this drug repeatedly to stop an episode of labor. In fact, you will probably see it more commonly given in a term pregnancy where the baby is showing distress because of uterine contractions coming too frequently. Then you will see it actually used to stop preterm labor. Use of this drug is considered off-label, and it is not approved by the FDA. But we use it anyway due to the benefit-risk ratio. The benefit is it is quick acting and it's easy to administer while we're getting ready to administer mag sulfate. Remember, mag sulfate has to come from pharmacy. We keep terbutaline on our unit. You can easily draw it up, administer it, and watch for the results. In the meantime, your mag is coming up and you can get that all set up and hung. Anyway, terbutaline produces common side effects that are associated with this drug class, the most common being tachycardia in the mother and then the fetus, a decrease in the blood pressure, tremors, and a headache. Let your patient know she should expect these side effects. Turn it into something positive, that when she starts feeling tremors and that her heart is going faster than normal, we know that the drug is on board and we're going to look for its therapeutic effects. Monitor the patient closely because these side effects will occur within minutes of administration. Similar to using magnesium sulfate for pregnancy-induced hypertension, we give the patient a loading dose of 4 to 6 grams IV over 30 minutes, and then we decrease it to between 1 and 4 grams per hour based on the contraction patterns. The MAG is continued for at least 12 hours after the uterine contractions have stopped, or if the uterine contractions are less than every 10 minutes. It also may be continued for a full 48 hours to allow us time to administer the 2 doses of betamethasone to promote lung maturation in the fetus. Another benefit of the mag sulfate in the preterm fetus is neuroprotection and a decreased risk of developing cerebral palsy if delivery actually occurs. The nursing management for a patient on mag sulfate for PTL is the same as for PIH. So refer to the lecture on PIH management for the dangers associated with mag sulfate, the important nursing assessments and interventions, as well as monitoring mag levels. I'm not going to repeat them here. When the contraction pattern meet criteria to be less likely to change the cervix, the patient is transitioned from mag sulfate to oral nifedipine, 10 to 20 milligrams. This is a calcium channel blocker. It is given anywhere between BID to QID, depending on the contraction pattern. You should recall from previous courses that the CCBs relax smooth muscle. Therefore, since the uterus is a smooth muscle, we can use it to reduce or stop uterine contractions. When a patient is on this, monitor her for orthostatic hypotension and report a pulse rate of greater than 120 to the obstetrician. Other medications that might be ordered include stool softeners to ease passage of stool, which results in less pressure on the cervix from straining. If the patient has an identified infection, you will administer antibiotics. Typically for the UTI and pyelonephritis, we will administer gentamicin. And as mentioned earlier, ampicillin or amoxicillin or azithromycin can be given for the other infections. When the patient is stable and no longer in labor, the physician must decide on whether or not we're going to keep the patient in the hospital in the antepartum unit or if we're going to send her home. If the patient is discharged, you need to provide instructions regarding continuing medications. She needs to continue the nifedipine, continue stool softeners. She needs to keep her hydration pattern up to levels according to her activity as well as the weather. She needs to maintain pelvic rest, which means no intercourse. She should also monitor for uterine contractions and fetal activity. Her activity levels need to decrease, and many of these women have to go on disability from their jobs. Some, especially if there's multiple gestations and we do send her home, will need to be on bed rest with bathroom privileges. However, research has not shown that maintenance of bed rest actually prolongs the pregnancy. So factors that lead to the decision to continue inpatient management versus outpatient include multifetal pregnancy, previous preterm birth. This patient had a previous episode of PTL and we already sent her home and now she's back. This time we're going to keep her. If her home life is difficult to manage, such as she has young children at home, she has no support from her spouse or her family, those type of issues, we're going to keep her inpatient. Remember that PTL can begin at 20 weeks, so a 17-week hospitalization can adversely affect the patient. We had a patient at Fountain Valley that went absolute stir crazy because we continually interrupted her day and night. She was exhausted. So we had to send her home, and guess what happened? She didn't maintain bed rest, she went about doing all her activities, and a week later she came in full-blown labor, and we delivered a 27-weeker. So look at the cartoon slide. It is not fun to be on bed rest. The patient needs a lot of diversion activities. Food intake may be minimal because she doesn't have an appetite because she's not moving around very much. The nurse is the person that comes in contact with the patient most often, day in, day out throughout hospitalization. Her husband or significant other still needs to go to the job, so that visitation may be only 2 to 4 hours per day. We will continue to monitor for fetal well-being and uterine contractions at least once a day. Most of the time, we're checking the fetal heart at least once a shift. As I mentioned earlier, keep your eye on these patients. They can have silent uterine activity that is dilating the cervix. All of a sudden, they put the call light on saying, "I feel funny. I feel pressure." Get in there quickly and evaluate her as she may be close to delivery. Trust me, that's happened on more than one occasion in my experience. Remember, the smaller the fetus, the easier it is to pass through the cervix without being fully dilated to 10 centimeters. So you need to provide the psychological support and social support. Remember our colleagues. Occupational therapy, physical therapy, recreational therapy. Get them involved. Get social service consultation if the patient needs support with funding, child care, those type of issues. Sometimes social services can even provide bus passes so that their significant other can come for a visit if they don't have a car. So preterm labor is a serious condition. We're trying to keep that baby in as long as possible to avoid a NICU admission. So the assessment and evaluation of this patient, interventions to stop labor and continue the pregnancy are going to fall on the nurse's shoulders. Thank you for listening and watching to the lectures on preterm labor.